Welcome to the Medicine Resident GI Lecture Series. Today's lecture will be on dysphagia. Let's jump in. The focus of our talk today will be on esophageal dysphagia. Here are our learning objectives. In the first, we'll identify the relative rates and the most common etiologies for esophageal dysphagia. Next, we'll learn how to implement an appropriate workup for dysphagia in the primary care setting. And third, we'll talk about differentiating between the diagnostic modalities for dysphagia, especially as they relate to the differential diagnosis for esophageal dysphagia, and jump into the differences between endoscopy, esophagram, and manometry. At the bottom of the slide here, you'll also notice this yellow key. Whenever you come across this key during our talk, pay close attention as there'll be key learning points. Let's dive in. There are two distinct etiologies for dysphagia. The first, oropharyngeal dysphagia, and the second, which is the focus of this talk, esophageal dysphagia. Briefly, let's talk about oropharyngeal dysphagia. In this type of dysphagia, patients often report symptoms of choking, coughing, drooling, or nasal regurgitation with swallow. People really have difficulty initiating swallow and need repeated swallows to clear their mouth of food boluses. Though patients pointing to their throat when asked, "Where is the problem with your swallowing?" can be helpful and more specific to oropharyngeal dysphagia, it does not rule out esophageal pathology. However, this whole constellation of symptoms together can help guide your next steps and referral to the correct specialist, in this case either ENT or our speech colleagues who may recommend a series of tests. Common etiologies we may come across in primary care clinic are listed here and include things like CNS disease such as stroke or structural disease such as malignancy. Okay, let's move on. The focus of our talk today is on esophageal dysphagia. Esophageal dysphagia can be broken down into two separate entities, the first being mechanical obstruction and the second, esophageal dysmotility. It's important for us to understand the etiologies of esophageal dysphagia so we can target our history taking in clinic. Here's a list of the most common conditions. The first group, GERD and esophagitis, comprises of about 30 to 40% of the etiologies of esophageal dysphagia. So asking questions about heartburn and reflux symptoms is key. Notably, eosinophilic esophagitis is on the rise, so keeping an eye out for a younger patient with dysphagia who might have atopic comorbidities such as asthma or allergic rhinitis is also important. We should also take a good medication history, including medications that are over the counter. Medications to focus in on would be things like NSAIDs, potassium supplementation, tetracyclines, and bisphosphonates. I'll next point our attention to the motility category. In thinking about medications, we're learning more and more about the role of opiates in esophageal dysmotility. Patients often correlate opiate use to constipation. However, the connection between opiate use and esophageal dysmotility is less well established. Lastly, I'll point us to the structural and mechanical causes bucket, 5%. This includes esophageal malignancy, a can't miss in our differential diagnosis. Now that we've reviewed the main etiologies for dysphagia, let's talk about implementing a workup. We'll follow these three principles: 1, localization, 2, tempo, and 3, red flags. Following these three principles can direct you to the correct specialist and also establish urgency with which workup needs to be completed. Most patients who have dysphagia, and specifically esophageal dysphagia, will be seen by a gastroenterologist. In this first step for localization, we can establish whether this patient needs to see GI versus ENT or speech. This distinction is established in your history. So again, reviewing oropharyngeal dysphagia as trouble with initiating swallow. In contrast, patients with esophageal dysphagia will often feel food gets stuck in their chest. They often do not have trouble initiating swallow either. Though patients with esophageal dysphagia may point along their chest where they feel food is getting stuck, this doesn't necessarily correlate to where the lesion may be. Because the sensory innervation for the esophagus is complicated, it's hard for patients to directly localize where the lesion may be. The main takeaways are that patients with oropharyngeal dysphagia have difficulty initiating swallow and may have adjacent symptoms of cough and may point to their throat, whereas patients with esophageal dysphagia describe food getting stuck in their chest, and localizing lesions along the esophagus on history is not always correlative to what we identify on testing. Let's move on to number 2, tempo. Once we've established esophageal dysphagia as the primary driver of this patient's symptoms, it's important to get a sense of what's been the evolution of these symptoms. Progression over months to years is typically more consistent with dysmotility, whereas progression from solids to liquids is more suggestive of a mechanical obstruction. Lastly, number 3, red flags. This can help GI risk stratify how quickly to schedule an EGD as the first step in diagnostics. The red flags listed here are important to identify and convey to your GI colleagues. These include fever, weight loss, iron deficiency anemia, odynophagia, and history of malignancy. I'll point attention to the 3 in this red box, however. If any of these 3 are present, intolerance to taken PO, inability to control secretions, or GI bleeding, melena or hematemesis, as these are all indications for emergent evaluation. It's helpful to let your patient know you'll be placing a referral to GI and to help prepare them that there may be diagnostic testing that involves procedures as next steps. Next, let's differentiate between the different testing modalities for esophageal dysphagia. The first step in evaluation of esophageal dysphagia is EGD with biopsies. This is direct visualization of the mucosa for structural abnormalities and also pathologic confirmation. It's important to take biopsies, especially given the rise of eosinophilic esophagitis, which is a clinical, endoscopic, and histopathologic diagnosis. Though EGD is the first diagnostic step in the evaluation of dysphagia, it's important to consider patients' comorbidities and the risk of the procedure. In these cases, sometimes an esophagram will be obtained before EGD. An esophagram is an X-ray series of the esophageal tract after barium swallow. For the highest yield protocol, you can request an esophagram with both liquid barium as well as a 13 mm barium tablet. This can help us identify differences in dysphagia between solids and liquids. Importantly, an esophagram may help us identify common causes for esophageal dysphagia that could be missed on an EGD. This includes things like achalasia, which may be suggested on an EGD given increased pressure at the lower esophageal sphincter when traversing with the scope. However, an esophagram would add further diagnostic weight to the diagnosis of achalasia with the classic bird beak image, as seen here on the right. Other diagnoses that may be difficult to identify on EGD but should be captured on esophagram are listed here and include things like Zenker's diverticulum, subtle narrowing of the esophagus or esophageal webs, as well as extrinsic compression from cervical osteophytes. One common area of confusion is the difference between a modified barium swallow study, or MBSS, and an esophagram. Modified barium swallow study focuses on the oropharyngeal phase of swallow, whereas a barium esophagram focuses on the esophageal phase of swallow. A comparison between the two can be seen here on the right column. Depending on the findings identified either on EGD or esophagram, our patient may need to proceed to manometry. Esophageal manometry measures pressures across the esophagus to evaluate peristalsis and sphincter relaxation, and it helps us identify primary esophageal motility disorders. To summarize, the 3 main diagnostic tools in the evaluation of esophageal dysphagia are EGD, esophagram, and manometry. Let's take a step back and put it all together. Dysphagia in itself is a red flag symptom that warrants further evaluation. It's important to first localize whether this is oropharyngeal dysphagia or esophageal dysphagia in order to make the appropriate diagnostic next steps. Once our history localizes to the esophagus, it's also important to identify the tempo or course of symptoms and identifying whether there's dysphagia to liquids, solids, or both. Third, the identification of red flags can be helpful to our colleagues in GI in terms of recognizing how quickly this patient will need to be seen in clinic and how expeditiously an EGD needs to be scheduled. Once a patient is referred to GI clinic, the first diagnostic step will be EGD with biopsy. Remember, though, that comorbidities are important to establish the safety and risk of a procedure. Therefore, in some cases, esophagram may be the first preferred modality of diagnostics. It's important to note that patients should be off of a proton pump inhibitor or PPI at least 2 weeks prior to undergoing EGD. If EGD and biopsy are negative for malignancy and the diagnosis remains unclear, while awaiting esophagram scheduling, you can start your patient on a PPI to identify whether there's symptom improvement. Lastly, manometry can help us identify the small subset of patients with motility disorders. Wrapping up, in this video we reviewed and identified the relative rates of the most common etiologies of esophageal dysphagia. Remember that GERD and esophagitis are the most common etiologies we encounter. Next, we applied a 3-principle assessment of dysphagia in the primary care setting by thinking about localization, tempo, and red flags as a framework. This helps us establish etiology and urgency of next diagnostic modalities. Lastly, we reviewed the differences in diagnostic modalities for esophageal dysphagia between EGD, esophagram, and manometry. This concludes our video on dysphagia. Thanks for tuning in.